specialists on the RAAB. They'll tell us what that means. And I heard that they've been carrying out throughout the country, and I'm very curious to hear from them. So at this point, I will invite Dr. Gishangi, who is the moderator for today's session, to welcome the presenters. Dr. Gishangi, are you there?
Yes, I am.
Karibu sana.
Asante sana. You can hear me?
Yes, but not very loudly. Is it me or is it you?
If I shout, you can hear me now? Better?
Yes, yeah, I think.
Okay, thank you very much. Dr. Oenga is on board.
Yeah.
Let her shout.
Yes, Daktari, I'm here. I'm here.
Okay, thank you. Thank you very much. I know Dr. Mude was worried that she has not spotted you. I've also seen Dr. Rono is there. Now, I'm going to start off by saying RAAB is Rapid Assessment of Avoidable Blindness, for those who may not have previously met the acronym. And it is a rapid methodology of assessing blindness in the community. And in the year 2022, in the month of September, specifically on September 8th, as one of the CMEs from this same community of practice for public health, we had some discussion on the RAAB surveys in Kenya that we were supposed to do. And that time we dwelt mainly on methodologies and the proposal that was something that was coming up. And between November 2022 and December 2023, we conducted RAAB surveys in 14 counties in Kenya. And today we are sharing the findings of the surveys. Dr. Oenga and Dr. Rono will actually do the technical detailed presentations of the findings. Dr. Oenga will briefly talk about the methodologies and the results. And then Dr. Rono will further discuss the results and compare with previous RAAB surveys done in previous years. You know, RAAB started in Kenya around 20 years ago, 2005 in Nakuru. And it will be interesting to know what changes have occurred over that period of time. Over to you, Dr. Oenga, please.
Thank you, Dr. Gishangi, for the brief introduction to RAAB. I don't know if I'm audible, Shiko.
Hi, Doc. Yes, you are.
I'm audible. Okay, so allow me to share my presentation. I'll try to really be brief because we have two presentations in one today. We are going to try and share the pertinent findings from the RAAB surveys in Kenya, and also look at a comparison of where we were in areas where previous RAABs had been undertaken. So in the next 45 minutes, Dr. Rono and I are going to try and combine these two presentations into one. So if I can just share my screen and start. Okay, so my name is Dr. Oenga and I work in Kajiado County. I will be presenting on behalf of the RAAB technical team that includes RAAB trainer, Professor Shiko Madenge, Dr. Gishangi, Dr. Rono, and other people that form the technical team for Kenya. There might have been people who were not present in the previous presentation where we discussed the RAAB methodology. So allow me to just take a few minutes to talk about RAAB and what exactly RAAB is as part of the introduction to this talk. And then I will talk about the Kenya RAAB series and the findings from the 10 surveys that we've done to date. So RAAB is really a standardized population-based survey that has been widely used globally in the eye care sector that aids in determination of the burden of blindness and visual impairment. The current RAAB version, or RAAB 7, was developed by ICH in collaboration with PIC, and it integrates collection using a mobile phone or a mobile gadget, as you can see in the screenshot here, that is linked to a server and allows for the data collectors or enumerators to directly upload the findings from the survey or the data they are collecting day to day. And then it also has a capability whereby administrators then set up a web-based platform where they can then monitor the survey almost in real time. If the enumerators are linked to the internet, the data is uploaded almost in real time, and it allows you to be able to pick up any issues, or if there are any errors, you're able to link with the enumerators to correct the same. The aim of RAAB is to estimate the prevalence and causes of avoidable blindness and visual impairment, to assess the cataract surgical coverage. So I will discuss this in more detail, because cataract surgical coverage is a proxy indicator for access to eye services. To estimate outcomes of after cataract surgery, which is also an indicator of the quality of service that is being provided in that population, and also to identify the main barriers to uptake of cataract surgery. So RAAB, or Rapid Assessment of Avoidable Blindness, is dubbed as being rapid because the survey is restricted to people aged 50 and above. The examination procedures are really simplified. The enumerators or the data collectors, in this case, the ophthalmologists with their assistants, do the enumeration and the basic examination in one visit. And then the RAAB software that is provided by PIC has end-to-end capabilities, from allowing you to do the sample size calculation, data entry analysis, report generation. The reason we focus on people aged 50 and above, if maybe someone might ask why we are only focusing in people aged 50 and above, it's because from studies that have been done, it has been found that up to 85% of blindness is in this age group, people aged 50 and above. In addition, the causes of blindness and visual impairment in that cohort actually reflects causes in the general population. So if you look at cataract, it will be 48% in 50 and above, while it's 46%. So you are able to extrapolate the findings of RAAB surveys to the general population. So yeah, causes in those 50 and above reflect causes in the population. So the reason we don't include the younger population or people aged below 50 is if, for example, you take people aged 40 and you include them in the survey, you will increase the prevalence or the proportion of people blind by 5%. So you will increase from 4,010,000 to 4.2 million, but your sample size goes up by almost 70%. This is because if you look at the prevalence of blindness in the people aged 40 and above, it's 2.6%, while in those 50 and above, it's 4.3%. The higher your prevalence, or the higher the prevalence of a condition in a population, the smaller the sample size required, because you need fewer people to be able to find those with the condition. So if you have a condition that is rare, or if the condition is rare in a certain age cohort, you need more people. You need to examine more people to actually find that problem in the age cohort. Yeah, so you need a 70% increase in sample size just to increase the number blind by 5%. So it's not cost effective, or rather the cost goes really high if you include people aged 40 and above. So this is just a schematic of the examination protocol for RAAB. The enumerators, in this case ophthalmologists, take the visual acuity. If the visual acuity is at least 612 in both eyes, then they will examine the lens to see if the patient is pseudophakic. And then if the patient is pseudophakic, they'll ask questions about cataract surgery. Where was the surgery done? What was the cost? And things like that. If the visual acuity is less than 612 in either eye, then the ophthalmologist will examine the patient to determine the cause of visual impairment or blindness, if the patient is blind, in each eye. And then they need to determine what the main cause of blindness or visual impairment is in the person. So someone can have two different causes of visual impairment or blindness, but as a person, then we need to determine what is the main cause of blindness or visual impairment in this person. And usually for RAAB, we look at things that are easier to treat or preventable as being the main causes, or they rank higher in terms of category or prioritization. Okay, so in summary, RAAB really gives us information that helps us to know where we are. So it is information that for counties, for example, in the survey that we're going to discuss that had not had previous RAABs or eye surveys, you are able to determine where are we in terms of eye services. This information then helps us to determine where do we want to go. If, for example, the prevalence of blindness is this high or is at this level, where do we want to go in the next 10, 20, 30 years? So it helps us to set targets. How do we get there? And after, maybe the 10 years that we gave ourselves to be able to intervene, and RAAB then can help us to determine the impact, or to determine, to help us know, have we really achieved the targets that we set out to achieve? Sorry. RAAB evidence also is useful for advocacy and for resource mobilization, because it helps you to determine what your burden is in terms of blindness, visual impairment. It also helps, once RAABs have been done, and as you'll see from the results, you're able to compare counties and also countries. So the study sites were selected based on the financial availability at the time. And some of these counties already had interventions ongoing. And so if you do a RAAB where interventions are ongoing, it helps you to understand, are the interventions being impactful as you go along in implementing the eye interventions. So at this juncture, I just want to say CBM supported 8 of the RAABs in the counties where they are currently implementing the Vision Impact Project, and Fred Hollows supported the RAAB in Turkana, and Homa Bay combined with Migori. So on to the RAAB findings for 2022-2023. So as Dr. Gishangi said, we conducted 10 RAABs across 15 counties. These counties are 15 because some of the counties were combined, and you will see that a bit later on in the discussion. The time period was between December 2022 and December 2023. The team composition, as I already said, we had a senior RAAB trainer. RAAB trainers are usually people who are accredited by International Center for Eye Health to be able to conduct RAABs. And so our RAAB trainer was Professor Madenge. We had 10 ophthalmologists and 10 assistants, actually 12 ophthalmologists. 2 were on standby or were able to come in when 1 or 2 ophthalmologists had other engagements. We used over 1,000 guides, and these were chiefs, village elders, CHVs across the 15 counties. We had field coordinators, the logistics team, the MOH led by Dr. Gishangi, and partners, as I already mentioned, CBM and Fred Hollows. Allow me to just put this up to show the response rate for these surveys. So the lowest response rate was 90.4 in Kajiado, while the highest was Kakamega Busia at 93.5. Response rates, as you may be aware, are important, because then if you have a very low response rate, maybe between 80 and 90, there is potential of introducing non-response bias into your study, because it means that probably there were people who were not available to be examined. If you take an example of the younger people, maybe they were not at home, you might skew your results because the findings in the younger people might not be the same as the people who are likely to be found at home or who are older. If your response rate is very high, 95 and above, it means that then you might be introducing a selection bias to your study, and selection bias would mean probably the enumerators are replacing the unavailable people. So if they find people unavailable in a household, instead of enumerating them as unavailable, then they just replace them. And the risk with replacing is that the people who are found at home are more likely to be the visually impaired. So you skew your prevalences of blindness and other RAAB findings. So that's why the response rate is quite important. So going into the findings, I'll discuss findings in 4 main categories: prevalence of blindness and visual impairment. And RAAB uses the ICD-11, the WHO ICD-11 categorization of vision, where blindness is presenting visual acuity less than 360, severe visual impairment is between 360, less than 360, but better than less than 660, but better than 360. Moderate visual impairment is less than 618, but better than 660, while mild visual impairment is 660, less than 612, but better than 618. Now, looking at the prevalence of blindness for the 10 RAABs that we did, you can see that Turkana had the highest prevalence at 6.2, while Nakuru had the lowest prevalence at 0.8. You can just look at the other prevalences. When we extrapolate this to the general population, this is the picture we get. Turkana still has the highest at about 0.49, which is less than the 0.5 that we've routinely been using for Kenya, while Nakuru and Kiambu had about 0.1% blindness in the general population. When we looked at the other categories of vision, severe, moderate, and mild visual impairment, this is the picture. The severe visual impairment was not that high, with the highest still being Turkana at 2.6%. Moderate visual impairment, then Turkana still had the highest at 13.7%, while the others ranged from about 10 to about 6.6%. Now, having looked at the prevalence of blindness and visual impairment, the other indicator that RAAB is able to tell us is the causes of blindness and visual impairment in the populations that we surveyed. So I'm not going to go through all the 10 RAABs, just allow me to discuss maybe 2 or 3 that either are a picture of what the other counties were, or are have a slight difference in the picture that they represent. So Vihiga really represents what majority of the other counties showed us. Cataract still remains the main cause of blindness, followed by glaucoma in majority of the counties. When we look at Nakuru, cataract then significantly is the main cause of blindness, followed by glaucoma again. And for Nakuru, actually, cataract was more significant as a cause of blindness than in the other counties. I put Kiambu Murang'a here because we would have expected diabetic retinopathy in Kiambu Murang'a, and this is one of the counties where we found DR, together with Bomet and Kakamega, Busia, but to a lesser extent. The other county that had a slightly different picture was Turkana, where you still have cataract as the main cause of blindness, but we then have non-trachomatous corneal opacity being significantly more frequent as a cause of blindness than the trachomatous corneal opacity. And those of us who work in trachoma counties, we know that Turkana, Kajiado, those are trachoma endemic counties. But from the RAAB, what we are seeing is that people had more non-trachomatous corneal opacity. This included the corneal dystrophies, band keratopathy, climatic droplet keratopathy. The other significant finding for Turkana was the phthisis. And this was mainly from trauma. So either people have been eviscerated or, the eye has just gone phthysical from thorn prick, injury while out herding. And so that was a bit different for Turkana as compared to the other counties. The causes of severe, moderate, and mild visual impairment included uncorrected refractive error, but cataract was still significantly a contributing factor to moderate, especially moderate visual impairment, but also severe and mild visual impairment. So looking at, that was Vihiga County. So we have uncorrected refractive error and untreated cataract. Kwale County, we still have uncorrected refractive error, untreated cataract. In Turkana, then we had the same refractive error, untreated cataract, but other corneal opacities were also quite significant, especially in the moderate visual impairment category. So having looked at the causes of blindness and visual impairment, then we can then categorize those causes as either being treatable, preventable, either by public health public health interventions or primary eye care, primary health care or primary eye care. Preventable through ophthalmic services. This means improving this delivery of eye care services in those counties or in Kenya. And in the other category, things that are not avoidable, for example, the ARMD and glaucoma. So the action that is required, having looked at those causes of blindness and visual impairment, cataract surgery significantly still the leading cause of blindness and visual impairment, and cataract surgical services still being required in these counties. Rehabilitation and law services for those that are causes that are unavoidable or unpreventable. Improving cataract, improving ophthalmic care services through things like improving the quality of cataract surgery, and I'll talk a bit about that. Primary healthcare and primary eye care, and optical services. So that is the findings about the causes of blindness and visual impairment. Now, the other indicator that is important from RAAB is cataract surgical coverage and cataract surgical outcome. The reason cataract surgical coverage is important, it's because it's an indicator that allows us to assess our the extent to which patients are able to access eye services or cataract services. So cataract surgical coverage is a service indicator. It measures the number of people in a population who have been operated as a proportion of all the people operated or are still waiting for operation. So in the RAAB, these are people who the main cause of visual impairment was identified as being a cataract, either in one eye or in both eyes. So the formula for calculating the cataract surgical coverage is X plus Y. X is individuals with unilateral operated cataract. Y is individuals with bilateral operated cataract. Z is those with visual acuity less than 612 attributed to cataract as the cause of that vision that is below 612. Now, cataract surgical coverage tells us about how people needing service have been able to access that service. Effective cataract surgical services is then that service, the quality of the service that is being offered. So it monitors the quality of service, and it is the proportion of those with good outcome over the proportion of all those that have been operated and those that still need surgery. So it is calculated as AB. A is individuals with unilateral operated cataract attaining 612 vision or better. B is 612, individuals with bilateral operated cataract attaining 612 or better in at least one eye. So looking at cataract surgical coverage, it is one of the tracer indicators that is being used to monitor progress towards attaining universal health coverage in eye services. Now, when we looked at the data that we collected from RAAB, this is a table that's a bit busy, but just allow me to go through it because it's quite important. So cataract surgical coverage is assessed at various visual thresholds. So we have the 360 vision category, 660 and 618. So if we look at, for example, the 360, which would be the visual acuity equal to blindness category, our coverages are not that bad. I mean, we have 85.6% at the highest for Bomet County and 57.6 coverage for Turkana. The coverage reduces as the threshold increases. So as you go towards better vision, our coverage reduces. When we go to the 660, which is equivalent to severe visual impairment, our coverage then reduces to about 76.4 for Nakuru at the highest, and Turkana still 46 at the lowest. And when we go to the 618, the coverage is even lower. Now, when we look at the effective cataract surgical coverage, so of the people that we've operated, what proportion of them have good surgical outcome? We see that then the numbers drop. So in Bomet, where we had 85.6% coverage at the 360 threshold, the effective cataract surgical coverage drops to 47.4. In Turkana, where we had 57.6, it dropped to 16.1. And this is true across thresholds and across counties. In every single county, we had quite a significant difference between those that are accessing cataract surgery and those that have good outcome from the service that we are offering in our counties. So Turkana at the 618 threshold had the highest relative quality gap. So relative quality gap is the difference between the effective cataract coverage, people with good outcome after cataract surgery, and the cataract surgical coverage, people who've been able to access the service. Nakuru at the 360 threshold had the lowest relative quality gap at 38.3. Okay, so sorry, yeah. So when we look at the cataract surgical outcomes, so cataract surgical coverage is about persons and how well they've been able to access the services for cataract surgery. Cataract surgical outcomes are about the quality of the cataract surgeries that have been done across these counties. And it is defined as either good, and in contrast to the National Eye Health Strategy, where we define good surgical outcome as 618 or better, RAAB defines good outcome as 612 or better, visual acuity of 612 or better. So good, 612 or better, borderline, below 612, so 618 to 660, and poor, below 360. So if we look at across the counties, so the blue is the good, the orange is borderline, and the gray is poor. All our counties, the 10 RAABs, none of them got to 60%. The WHO recommendation is 80% for the good outcome and less than 5% for the poor outcome. So we had Kwale County with the highest in terms of the good outcome at 49.5, while Met is Meru, Embu, Tharaka. They were done as a cohort at 47.9, while on the lower end we had Kajiado at 32.9 and Turkana at 23.8. Kakamega, Busia, which were also combined, had 33.8. Now, a caveat at this point, cataract surgical outcome
Dr. Oenga, you seem to be muted.
Screen actually looks frozen. Maybe she's having challenges.
She's still off, but she's trying to exit and return.
Don't call me.
You can. Evans.
Sorry, I'm so sorry I got dropped off the call. I don't know if I'm still sharing or I should share again. Am I audible?
Share
Yes, we
again,
can
share
hear
again. I don't know.
I share again? Okay, fine. So let me just take the next 5 minutes to wind up so that I allow Dr. Rono to come in. I don't know is the presentation visible?
Yes,
Please.
Yeah.
Yeah, okay, so this is just a table that shows across the 10 RAABs that we did, what the outcomes were by category, whether good, borderline, or poor. Now, when we looked at the visual acuity without pinhole, with pinhole, then this is the pinhole VA, and you can see that our outcomes then improve significantly. You remember none of them were getting to 50% in the good category. And now here we have Kwale at 72.2, still below the 80% threshold, but much better. And when we looked at the causes of poor outcome, so it was mainly selection and surgery accounted for borderline and poor outcome, spectacles mainly for borderline outcomes, and sequelae including PCO for borderline and poor outcomes. Barriers to cataract surgery, I will not belabor this, but across the counties, the barriers were almost quite similar. And remember, RAAB did not have a qualitative aspect, it was quantitative. So patients were just given options to pick from. And you can see for Vihiga, the most significant reason that patients said they had not sought intervention was cost. Same to Migori, 42.4%. While in Nakuru, also cost was quite significant, followed by being, they were not aware that surgery is possible. And Turkana, cost, but also awareness. Now, I will not go too much into the refractive coverage and effective refractive error coverage, but this is a second indicator that then allows us to assess access to eye services and look at the quality of services in terms of refractive error services. So of the people who've received spectacles, how many of those have normal vision or 612 VA or better, which is the met need. Of those that have received spectacles, how many have VA less than 612, but improves with pinhole to 612, so they still have a refractive error despite having spectacles? So that's the under-met need. And people who have refractive error but have not gotten spectacles, so that's the unmet need. So looking at across the counties, the refractive error coverage, comparing with the effective refractive error coverage. So those for whom spectacles are correcting them to normal vision, this is the picture that we get. The highest coverage was actually Kajiado, 10.6%, which is still quite low, with the 9.7% of those who had spectacles, their need having been met, meaning that their spectacles were correcting them to normal vision. So implications of RAAB surveys, as I had already said, RAAB serves as a baseline. It allows us to also monitor interventions and the services that we are offering, and allows us to evaluate the impact of eye health interventions over time. RAAB would also allow us to track changes in prevalence and visual impairment, and Dr. Rono will talk more about this. It can help us to identify priority eye health issues, as we have already discussed, the causes of blindness and visual impairment, but also looking at the service that we are offering, the proportion that we are able to reach, and of those that we are reaching, what quality of service are we offering? It can also help us to assess uptake of services and barriers to the access of these services. So let me just acknowledge the team, the CBM team and Fred Holos for the funding, OSU, Professor Madenge, the RAAB trainer, the RAAB advisory committee, the RAAB team that did an exemplary work, and the logistics team. Thank you very much, and karibu, Dr. Rono.
Thank you, Dr. Oenga, and thank you all the listeners. I hope you can hear me. Let me share my slide. Can you see my presentation?
Yes, Dr. Rigon.
Yeah, thank you. So thank you, Dr. Oenga, for doing an introduction, and that simplifies the work that I'm going to do and maybe shortens the time. So I'm Dr. Rono, an ophthalmologist based here in Trans Nzoia County in Kitale. And also I do some work for Peak Vision as well. And we were part of the survey team that conducted all these RAABs in Kenya. This time I'm going to present about basically looking at the progress we have had in eye care services in Kenya, based on basically 3 regions, which are Kwale, Nakuru, and Migori and Homa Bay, previously called South Nyanza. And these are because we have 2 previous RAABs that have been done in these regions. Basically, as the first speaker had said, we need data basically for planning to know where we are going, to set targets as well. But also we need data to actually review our progress and basically to see whether we have achieved our targets or we still need to do something about it. And this one basically, or my presentation is basically going to be based on review of basically service delivery over the last 20 years in Kenya. So I'm actually going to present about serial RAABs. This one has been discussed before. In a RAAB survey, we do get people who are, we assess people above 50. We get people who have normal vision and those people who have visual impairment. We also get to know people who have had visual impairment and have been treated. These are the ones who are treated by the green color here, and those who are still blind. And with that, then we are able to get prevalence of blindness. We also able to get prevalence of visual impairment. And of course, we are also able to get the proportion of people who have been treated, and we're able to get the effectiveness of our treatment, and of course, the barriers that have been said before. So what we all aware, or what we know, is that basically all of us here are providing eye services in one way or another, whether in public, private, or faith-based, or even funders, or even supporting eye care in whatever case. And basically the aim of all of us is basically to present disability, and in this case is blindness, and of course to provide that services in an equitable way. So over the last 10 years, then how have we been able to do in terms of preventing this disability? Every month, then we also do present to the Ministry of Health monthly reports, giving us the proportions of the diseases that we have seen. That's basically trying to monitor the progress. But then the question is, what have been the impact of our activities over the years that we have been doing it? And do we need to change the approach, or do we just need to still do things the way we do? And probably to answer some of this question, we reviewed data from the 3 counties at 2 time points. And we basically, the previous RAABs, we looked at the RAABs from repository, which is kept somewhere in a RAAB repository in that website. And as you can see from the repository, what we found out was that there are about 4 RAABs which have been done before 2022. Between 2000 and up to 2022, there were only 4 RAABs which have been done in Kenya, and which are in the repository, and we were able to get that information from there. We also looked at the publications which have been done, and one of them was this one, which was a rapid assessment of avoidable blindness in Nakuru in 2007. And there's some. We also looked at the reports from previous RAABs. Thank you. I thank Professor Shiku Madenge for giving us the previous reports. This was a training somewhere in Homa Bay, South Nyanza in 2010. We also compared that with the results from the current RAAB surveys, which have been presented just now. And of course, the current RAAB survey took us all the way from Lokitang. You can see all those are Google maps from our phones that basically tracked where we were all these times for the last 1 year. And of course, we met various cultural, we met various people with diverse backgrounds. So one of our study areas is Kwale County. And in Kwale County, we have had a follow-up of about 12 years. The first RAAB was done in 2011, and we did the second one in 2013. That makes us 12 years. The other one is Nakuru County. And in Nakuru County, we have had a follow-up period of about 18 years. And the first RAAB was done in 2005, and the second one was done again last year, 2023. And then in Migori and Homa Bay, previously called South Nyanza, they have had a follow-up period of 13 years. The first RAAB was done in 2010, and the other one was done last year in December. So those are the same for the 2 counties. So basically, I'm going to present the progress for comparison, basically in 3 areas: prevalence of blindness, what has happened in the prevalence of blindness, what has happened in terms of access to services, that's the proportion of people, or what has been the coverage in terms of cataract services. And also I try to look at in terms of quality over those years, looking at cataract surgical outcomes as a proxy for the quality in those 3 areas. So those are the 3 proxy data that I'll be using. And what are our findings? Yeah, this was some of our team members looking for network somewhere in the field survey. So I'll start with Kwale County. And as I'd say that the survey was done in 2011, and the prevalence of blindness at that time was 2.7%. And that has basically reduced to about 2% from the survey that we did last year. That's a drop of about 26%. In terms of coverage, what we found out was that in terms of the people coverage of the people who are blind, that's less than 360. In 2011, it was 75%, and that one is still about 74%. That's almost same level. In terms of coverage of the people who was less than 660, it was 66% then in 2011, and basically almost same stagnant, but around 68%. In terms of surgical outcome, we find that the people who could not see 660 after surgery in 2011 were 18.7%, or just 18%. But in 2023, that number dropped, which means there's an improvement in quality to about 12%. That's basically a drop of about 30%. And in terms of people who could see 618, that's the ones who could see better than 618, we had 61% in 2011, and then to 71% last year. That's basically an improvement of about 16%. So what we can actually say for Kwale County, the coverage, basically access remained nearly the same, stable, but the quality of cataract surgical was actually improved significantly. And of course, the blindness reduced. When we go to Homa Bay, Migori County, which was previously South Nyanza, the prevalence of blindness dropped from 3% in 2010 to 2.4% last year. That's basically a drop of about 20%. In terms of coverage, among the ones who are blind 360, we find that the coverage in 2010 then was about 26%, and that improved almost 3 times to about 64%. In terms of the coverage, people with vision about less than 660, we find that it was 23% in 2010, and that has actually improved also about 3 times. That's about 144% to 56% in those 13 years. But in terms of the quality of cataract outcomes, we find that after surgery, those people who could not see 660 in 2010 were 26%. In 2023, or last year, that number increased by about 6% to 28%. And the people who could see 618 after cataract surgery in 2010 were about 59%, and that number dropped to about 6% as of last year. That drop was about 39%. So you could actually see that in the Homa Bay, Migori County, the coverage was excellent. It actually almost tripled, but there's a concern in terms of the quality of cataract surgery. So that's basically what you're getting in those in Migori and Homa Bay counties. In Nakuru County, the prevalence of blindness reduced from 2% in 2005 to 1% in 2023. That is basically a drop of about 50% in terms of blindness, but that's a follow-up period of 18 years. In terms of coverage, for the coverage less than 360, we find that in 2005, it was 78%, and that increased by about 5% to 82%. And the coverage among the people who are less than 660 for cataract services, we find that it was 70%, or 71% in 2005, and that improved to about 75, 76% last year. And in terms of cataract surgical outcome, the people who had vision less than 660 after cataract operation were 22% in 2005, and that actually reduced by about 32% to 15%. And those who can see or who could see 618 or better in 2005 were 49%, and that improved to about 58% as of last year during the RAAB survey. That's basically an increase of about 18%. So overall, we find that the coverage and the quality of cataract services is basically improving in Nakuru County. So in conclusion, therefore, in the 3 counties, and if we are to use that, the 3 counties as an indicator for service delivery in Kenya, we find that the blindness in Kenya is basically reducing. The cataract surgical coverage is increasing, though it varies from one region to another. There is, of course, a concern in terms of the cataract surgical outcome, which has been variable in the various counties. And overall, there is need actually to do serial RAAB surveys to assess basically service delivery. But of course, the concern basically is how often should we do it? Should we do it after 10 years or should we do it after 20 years? And basically a question I was asking myself is, are we in the right path in delivery of eye care in Kenya? And probably the answer is yes, general direction is good. I would like to acknowledge the various people, that's the government, the county governments, for their support. And of course, the teams the trainers and the PIs, the survey team, and the funders as well for this work. Thank you very much. Hello?
Hi, Dr. Rono, we can hear you. Thank you very much for the presentation. I'll hand over back to Dr. Gishangi if he's still with us, so we can look through the questions, and a few questions I've seen in the chat for the presenters. Dr. Gishangi, are you still there? All right, maybe I can start with the first one, Daktari. I've seen a question in the chat. Dr. Situma was asking, how would you address the issue of patient selection? Sometimes moving a patient from HM to 360 is the best attainable in any circumstance. I think he typed this when Dr. Oenga was speaking. So perhaps, Dr. Oenga, if you're still there, you can tackle that.
Yes, sure. So what I would say is that WHO recommendation does not expect 100% of patients to have good outcome. That's why they put the threshold at about 80%, because then there are those patients with probably coexisting ocular comorbidities or even systemic issues who, for one reason or another, you cannot get them to within normal vision or get a good outcome. But having said that, for each of these counties, we can then do a sub-analysis. It wasn't possible to really present in-depth findings for each county to say, for example, Vihiga County, of those with the poor outcome, how many were due to selection? So that then we can say that, yes, selection was the issue in this county. How many were due to probably surgical complications, because then that brings a whole other aspect to it. So yes, it's expected that some patients will have poor outcome or borderline outcome due to underlying problems. And that is why the 80% threshold, if you get to 80%, then it means probably 15% will be borderline due to selection issues. Another 5% will be poor because, they probably had end-stage glaucoma, but there was a dense cataract, and you wanted to see if you can give them some navigation vision. Thank you. I don't know, Rono, if you have any addition to that.
No, thank you. I think that is answers very well.
I've seen again in the chat box, Dr. Mashep was asking, perhaps as a follow-up to that, how much does biometry, particularly when we talk about the cataract outcomes, how much would you attribute to presence or lack of biometry? That was a question by Dr. Mashep.
So thank you again for the question. So in the presentation, I don't know whether it's at the point at which I dropped off, but I tried to show cataract surgical outcomes presenting visual acuity vis-a-vis pinhole visual acuity, which then, for those that improve, you then identify refractive error as a cause of your poor or moderate or borderline outcome. So yes, definitely lack of biometry does contribute, and as we saw, quite significantly to borderline or poor outcomes, because when we compared the graphs, there was quite a shift in terms of the percentages that moved from borderline to good when we did pinhole VA.
Oh, great. I can see Dr. Gishangi is back. Daktari, karibu.
Yeah, and
Santi,
then
we just continue.
Yeah, one other contribution there would as well be that in the same edition, you can see that for Kwale, for example, it improved from about just maybe under 49 to about 72%. That's basically about 30%, yeah, 20% jump. So you can actually say biometry does contribute. And I think I'd be bold, I say this, but I think there should be no cataract surgery basically without biometry, because you are basically doing a disservice to the community. But I think biometry is quite good. I mean, we need to do biometry on all patients. Thank you.
Okay, thank you very much. Austin Odero is asking, are we able to disaggregate the results per county, since I see some counties like Homa Bay and Migori were merged?
Yeah, in terms of as a survey unit, we did the two counties as one unit because we wanted to have a longitudinal data based on what had been done before for basically comparison purposes. In terms of the burden of the current burden in the two counties, it is possible because you're able to get the proportion of people above 50 and just, but there's an assumption there. One assumption is that you'll just say that the level of blindness in the two counties is the same, but the only variable which will be there likely be the proportion of people who are older. Who are older than 50, the proportion of people who are older than 50 will contribute to the magnitude in the two counties. But the basic assumption is that you'll actually have a blindness similar in all the three, in the two counties, Migori, Homa Bay. Yeah.
I hope you've been answered. But additionally, he asks whether did you collect any data around the factors surrounding the surgical outcomes, or would we need to do an excerpt to further supplement the RAAB results? I don't know what an excerpt is. Maybe we can start from there.
Maybe I look at that. EXAT is Eye Care Situation Analysis Tool, and it's a health system approach looking into different factors that come into play when delivering eye care services, including the personnel doing that, the available resources, and so forth. Now, we described RAAB as rapid assessment of avoidable blindness, and it did not go into the details of finding the reason for poor outcome. It quantified that this level of outcome, but did not try to go into the details of that. That would be something we can look into. Now, just trying to respond to another question which is on the way, the issue of quality going down. The idea is when we are evaluating our quality of services, you try to analyze the patients who had poor outcome or poor quality and try identify an area that needs further intervention, improve, and then try find out if that has improved in terms of outcome, after the intervention. So we will, in terms of quality of outcome, we will progressively continue to provide some interventions. Like you might ask yourself whether having biometry or not having biometry has any effect on the outcome. And so you intervene with biometry and find out what is the outcome, or any other procedure that may have been used in the county or in the facility, and then try analyze the outcome. And progressively, it will definitely change.
In fact, I can see you just mentioned, you touched on a question Dr. Kimani is asking, that it's very worrying regarding the drop in quality of cataract surgical outcome in Homa Bay. It might mean that we are creating irreversible blindness. Is there any explanation for this situation? And is there any intervention being instituted?
The intervention that would be to investigate the circumstances around the service delivery within the Migori, Homa Bay counties, and then identify what to intervene. There's a cause for alarm. There's a reason to dig deeper into that.
Okay. Dr. Kibata has said a few questions from him. So what would be the national average stroke prevalence of blindness, and can this figure be disaggregated per county and causes? And he also says that he has been saying that cataract surgery should not be done without biometry and a vitrector, perhaps an anterior vitrector. And he says these are irreducible minimums.
Dr. Rono?
Yeah, I will answer probably the first
one. Yeah.
When we did the average of the current RAABs, basically the average comes to about 0.25, 0.3 there. But at the moment, we cannot label this a national. We cannot label it national. But basically, what this one tells us is that whatever we have been using for planning of 0.5 or 0.7, 0.7 was actually was from one study which was done in 1982, and that has been carried on over and over years. But the figure now on the average of these three is basically 0. Of these 10 RAABs is around 0.3. But that's just algebraic kind of average. But basically, we have to do what we call weighted average, because there are some areas which have higher population, therefore we'll have to have a higher weight. That's actually what we are working on at the moment in terms of trying to see what could be the national average, trying to see what weights to assign to where. But however, there will be one maybe limitation to this average, in that there are some areas which we have not done RAABs. Basically, we have the areas of the former Eastern Province and basically Northeastern Province, but we can actually say we can have a working figure, which is a composite figure for all that. Thank you. So, of course, this one has an implication in terms of what we have been planning. And I know most of us have been planning using like the figures of maybe 0.5 or 0.7. So you're expecting probably 10,000 cataracts, but when you go there, you find less than that. And this one basically what it means is basically we have been overestimating our burden of blindness. Maybe probably the right figure is where the averages is like. So maybe the figure could have been about maybe 6,000 instead of the 10,000. So I think that basically sets our targets as we go along. Thank you.
I don't know. Does this change the WHO CSR figure? If our prevalence is so low, or the CSR, the 3,000 still remains, what's the effect of that?
CSR is cataract surgical operations per million population. I think CSR is basically influenced by two things. Basically, it is at what threshold are we operating our cataracts? So if you're operating at 360, basically our CSR will be quite low. But if for example, we improve technologically and we're able to do 618, 624 cataracts, then we approach towards that 3,000 figure. The other bit as well we have in that perspective would be, then you see at the 360 threshold, very few people, but at the 618 or 624, there are multiple people, and I think that's more of a driving factor. And the CSR is per population. I mean, it's per million population. I think it could have an effect in terms of the number of cataracts that we do have, yes. But of course, what the main driver of that could be at what threshold we are able to operate our cataracts. What's our operable threshold?
Okay.
Professor Karimurio wants to throw in a spanner in the works, and he says, is it biometry that's the issue, or is it the lack of a wide range of IOL powers?
I want to say that it is both and none. And I say that because if there is demand for varying powers of intraocular lenses, the market will provide. If and that will be created by being able to do biometry. And if you don't do biometry, you will not have range. So it's two-way. We have to invest in biometry and also use the evidence of the biometry finding. I know the dissertation of Dr. Kabiru in the year 2000 worked on biometry in large scale, where we have seen somebody has tried to look at that. And her finding was that the range of different powers from, I think, 19 to 24 with a peak at 21 and 22. We also studied that later on in the later years, around 2008, and it showed the same. But we still need to continue gathering that information and using it to to make orders, of intraocular lenses. But there is need to consider using biometry in cataract surgery as a standard procedure. But we also need evidence to show that when you use biometry, the outcome is good. When this evidence is documented and repeated, then we have a strong voice, technically speaking.
I think you've even touched on Dr. Mingaine's question, whether it is possible for a large volume center to analyze their biometry findings to share the commonest powers found, and that this would help in procurement of IOLs.
Yeah, thank you.
Yes. So Dr. Sitati says, very good presentations, very informative, and she is requesting for this to be presented at the COEXA Congress.
That has been hatched.
All right, so Kennedy Alwenya saying that he saw a map. In the map, a large part of the country has been left out and certain counties and regions missed. Nationally, how will these findings be represented? Although I think Dr. Rono touched on that.
Okay, Dr. Rono or Dr. Oenga?
I think Dr. Rono already, sorry?
Touched to that. Okay.
Yeah, Dr. Rono already talked about it. And what I just wanted to say, the map that I projected did not have Turkana County. So sorry for that. So up here, we should have shaded Turkana County as part of that. But again, remember, this was not a Kenya RAAB. It was not a national RAAB because our sampling frame was not Kenya. These were RAABs done for individual counties or a group of counties. And the findings then are to be used at that level. Although, as Dr. Rono had indicated, we could extrapolate and try and come up with a composite figure to work with as a country for where we are in terms of blindness and visual impairment. Thank you.
Thank you, Dr. Oenga. Dr. Inoti is asking whether we have a good brand standalone anterior vitrector with at least 1500 CPM. Maybe someone can respond to him on the side. If there are any other questions, please feel free to unmute and ask the panel. We are at 7:40, so if there are any burning questions, you have a minute because today we don't have sponsors. Any questions? Going once? Twice?
Sorry, how are you?
Fine, thank you, Prof. Please proceed.
Thank you very much for the presenters and even him for this good presentation. I am in a place where lights are like disco. They are going on and off. But all the same, I hope I'll be able to make my point. The point that I want to add is what I have added last. That as a country, I don't think we need to start thinking about adjusting our CSR targets. For a very simple reason, that cataract surgical rate is not based on prevalence. When we come to RAAB, we are doing the prevalence of blindness and prevalence of blinding conditions. But what is required is to know that CSR just take care of the new cases. For example, if I give an example of cataract, which has been asked, we have seen that if you look at the coverage, and you look at coverage for less than 360, for 660, as you increase the threshold, actually the coverage is coming low. So the cataract surgical rate, which is the number of cataract operations done per million people per year, is supposed to make sure that there is no new cases. And it is assumed that the people who have cataract already will either be treated or others will go out by natural attrition, because you still have some dying with cataract. So it's not a RAAB which should address the issue of CSR. It is actually an incidence study, it's a longitudinal study. But because that is very expensive to fund, it is not like a cross-sectional study like a RAAB. That is why there are standards which are given for CSR. And it is known for Africa, this is the level of CSR which is needed. That is why CSR is prescribed. Thank you very much. I don't know whether I have made the explanation more complicated.
Dr. Kibata, that was your question being addressed. Okay, Bonodero, do you want to unmute and maybe say your point? And then we can wrap up, please.
Oh, thanks. A very good presentation and good work that has gone into this. I was just picking around these where we are in terms of the outcomes. So again, if you can build up a cascade framework around that, so that if today we are at 40%, in the next 1 year, where do we want to go as we move towards the 80, 85 or 90%? So then we become more intentional in how we invest around building up that cascade towards the required targets over a period of time. I'm sure that informed with good data, meaning partners like now Fred Hollows and government should also invest a lot more in research to really support some of these frameworks that then could help improve around this year.
Okay, thank you so much. Dr. Gishangi, any final remarks as the moderator of the session?
Thank you. This is work that began a while back and it is still going on. So what we are doing next is generating county briefs, the specific report for the county in some actionable way, trying to interpret the data to being actionable interventions. So we are doing that slowly by slowly and hope that by the end of this month, we'll have what you would call a report for the county or a county brief. Then we will go ahead and compile the whole report and what it would indicate or how it would talk to the Greater Kenya and how we would use it for planning and policy making. And as Dr. Rono and Dr. Oenga had said, this is very important information that can be used, especially at the county level, to plan and evaluate ourselves after a series of interventions. You have seen Nakuru in the year 2005 and the year 2023. Of course, several interventions have taken place and we can see reductions. Where we are noting that things are not going right, then we have a reason to dig deeper and try, intervene and improve. And for sure, we will do that. So thank you very much. And back to you, Dr. Muthee Wanjiku.
Thank you so much, Dr. Rono, Dr. Oenga, and Dr. Gishangi for that insightful presentation. The members agree it has been very eye-opening. We look forward to the report. And without further ado, I think our time is far gone. So allow me to end the meeting. Our next meeting will be in the next 2 weeks, and we will post on the board on the topic. Otherwise, thank you very much and have a good evening.